Well, thank you for including me in this session, which is a topic of daily interest to me. I hope that all of you had a chance to go to Dr. Brunt and Dr. Lewis's talks this morning, because they struck me as being important and interesting, but also very true to the personalities of the speakers, so that Mike's talk really reflected who he has been as a person, as a surgeon, as a leader, and the sort of integrity and the simplicity. And Frank's talk also reflected who he is in terms of a very broad thinker. And Frank also has a tremendous amount of integrity, and so I would say particularly as a surgeon, it's not that common a characteristic to be willing to change your mind. And what I've seen in him in the 7 years that I've worked closely with him is that he takes in new information every day. And so he could have been married to an idea as the right answer for years and years. And then if he learns something that shakes that, he's very willing to change his mind, which I think is admirable and becomes increasingly difficult as we get older and isn't really that much of a characteristic of surgeons. So that's something that I sort of admire and aspire to every day. And with that in mind, I was a little worried when I saw what his talk was and then this luncheon following, because I thought if he's learned something as he put everything together, it could completely erase the entire topic of this luncheon. And as he did in his talk, I'm going to say that I can't really speak for the American Board of Surgery, because the American Board of Surgery does not have a stand on this right now. It's been the topic of heated, frequent, at least weekly debates, at least 6 retreats since I've worked with the board. And I do think that we are honing in on answers, but we don't have them yet. So this is really what I think and sort of what we've distilled over time. So as I look at the issue, I look at it sort of backwards, which is the end product of surgical training. So we got a lot of complaints, starting around 2004 till about 2012, that the residents weren't prepared, they weren't doing well on the exams, they didn't feel good about themselves, they didn't feel ready to go into practice. But we never got any complaints about fellows. The finished product, however they were finishing, whether they were finishing through an ACGME accredited pathway that led to certification or through a non-ACGME accredited pathway, no one was saying they don't know what they're doing, they don't feel comfortable operating on their own, they're not autonomous, they're not prepared. So at some point between the end of surgical, the 5 years of surgical training and what I'll call the terminal training, which is the fellowship training, something happened that made things be okay. So then we started looking at the question of, well, so what is that thing that happens, and how can we sort of incorporate it and make sure that it happens to everybody? So one step is, as Mary pointed out, that half of the fellowships, 80% of our residents do fellowships, half of the fellowships are ACGME accredited and certified, and half of them aren't. We know very well what goes into the ACGME accredited ones. We know very little about what goes into the non-ACG accredited ones, and that falls across an entire gamut. So the Fellowship Council overseen fellowships are quite well defined, and then there are other ones that become more opaque. The endocrine fellowships, the burn fellowships, some of the breast fellowships are less well defined, less clearly overseen, which is not to say that they're not good quality, it's just that there's not a standard measure or a standard way of looking at those things. So we start to say, well, everybody benefits in the end from doing some sort of terminal training, or it certainly appears to be the case. You say, well, is it okay for the terminal training to be sort of in multiple different directions or from multiple different sources? And it's my feeling, and I think growingly the board's feeling, that the terminal training should be held to sort of a set of standards in the same way that the 5 years of residency or the 4 years of medical school are held to some sort of standard. So if we understand at what's going on in those last 2 years, is there some overlap with what goes on in the first 5 years? And to me, the answer is yes. So we hear a lot about how, there used to be 5 years of training and we didn't work 120 hours a week. I don't know anybody here who worked 120 hours a week. I worked between 125 and 140 hours a week. So I lost 2 full years of training when they went into the 80-hour work week. But the common comment is, well, you can't shorten the training because we've already de facto shortened it by cutting it down to 80 hours. And I would make the argument that there's still a year. I'm not going to say it's wasted, because very little time spent taking care of patients or working with your colleagues is wasted, but it certainly is not driving you toward your end goal of what it is that you're going to do every day in your practice when time goes by. I think we could all agree that you can probably pull a year out of activities or rotations or both that aren't driving you towards that end goal. So The flexibility and training pathway is distinct from the FIST program, and Mary's correct that every resident in the country whose program can allow it and whose program director supports it can modify their rotation schedule. They can do 12 months in the last 3 years of specialty training, allows them to start focusing in on that. So when that first passed in 2011, as Mary mentioned, we put the question to the fellowships, because we invited representatives from most of the fellowships to that retreat. We put the question and said, if the residents do 12 months of training in, let's say, transplant, before they finish, can you shorten the transplant fellowship by a year? To a fellowship. They all said, no, we can't do that. You know, we need the time, we need the service, it's disruptive to our processes. And so that was 5 years ago. One of my favorite things about doing this kind of work is that over time, things kind of level out. And over time, good ideas and fair processes and good metrics will bubble up to the top. So just this week, I got a phone call from a fellowship director saying, we have a really good resident who wants to go into our field, who we want to put through the flexibility and training pathway. We want to give him 12 months of specialty training during his residency, and we want to shorten his fellowship by a year. Will he still be eligible to sit for his ABS exams? So that's the exact question we posed 5 years ago, and everyone said no. And now it's kind of, because we've seen the effectiveness of the flexibility and training and FIST programs, it's started to seem like a reality. And the answer to that, of course, is yes. You can absolutely do that. That resident is going to meet all of their ABS requirements. They'll be able to sit for their exams, and it really falls to the fellowship at that point to decide if they've met their standards. And so it sounds like that's going to work. So that's my sort of index case for moving things into a 4+ something training program, because that resident will functionally have done 4 years of general surgery, 12 months of their specialty training, and then an additional 12 months of their specialty training. So I find that very exciting. What are the other pieces that are kind of moving into a place to allow this thing? The ABS voted in January to allow residents to take the qualifying exam after their 4th year. The mechanics of that, which are probably more vast than I can actually anticipate, haven't been put into place. So it's not true this year, but I think it's going to be true next year. So if a resident who has met all of their requirements, there's 750 cases, there are 150 chief level cases, FLS, ATLS, ACLS, the observed interactions and operations. If they've met all of those requirements, the only requirement not being met is the additional 12 months of residency. They can sit for their qualifying exam after their 4th year. So that's a very interesting, it doesn't mean that they're board eligible because they haven't finished their training yet. It just means they can take their exam early. And that to me is a mind shift, because it means, can you meet all those requirements in 4 years? Can you kind of condense everything down and feel that you have the knowledge to be ready to sit for that exam? So I'm really interested in how many people actually raise their hand and say, yeah, we want to do that, or yeah, we can do that. I'm going to guess it's going to be very few the first year, and it was very few for the flexibility and training pathway. I was the person for whom all of those applications passed through at the board. And the first year we had it, I was really excited, and I got about 3 people saying that they had a resident each who wanted to do it. And the next year was 12, and the next year was 18, and the next year was 30. And it's not a ton still, but it does still happen. And I think the same thing will happen with the qualifying exam. I think it'll be a few residents the first year, and then it's going to be 30, and then programs are going to start to realize that they can do it. The residents are going to start to realize that they want to do it, that there are advantages to do it, that they're looked at differently. If they've passed that hurdle in their chief year, they might be more respected, more trusted, have a better quality year. They may understand that they can kind of compress their general surgery into that period of time and then expand into things that they might be more interested in their 5th year. So all these things are things that sort of shift towards a de facto 4+ something. Will we get to a point where there's an official 4+, that the core training is 4 years, and the additional training is after that? I'm not sure. It seems likely, but I can't put my foot down and say that that's so right now. What I do know, and it's been alluded to a couple times today, is that 4+ includes everything. So 4 is not the terminal training of a general surgeon. There's no way that that can happen or be so, not in our culture, not in our society, not the way that surgery is set up. It's true in other countries, and they just manage things differently. But general surgery will also be 4+. General surgery will probably be 4+2, or at least 4+1. And it has to be a pathway with the same sort of rigor, measurements, milestones, and specifications as any of the other additional training pathways. So it's a shared core, and then additional training for general surgery, of which there are probably a few different limbs, general surgery with an emphasis in something, depending if you know what your targeted practice is, and then all these other specialties, the 23 other specialties that Frank mentioned today. So I think we've actually made quite a bit of progress that just hasn't had a bright label on it. So I think we're quite a bit closer to 4+ something than we ever were before. We're continuing to head in that direction, and I challenge any of you with residents to see if you can prepare them fully to take the qualifying exam after 4 years starting next year.